Okay.
Please start.
Okay. Good morning, everyone. My topic for today's discussion is management of congenital cystic eye using various sclerosing agent. And it's a rare ocular malformation first reported by Taylor and Collis in 1906. In 1939, Edmund was the first one to coin the term congenital cystic eye or an anophthalmos with cyst. It can be microphthalmos, anophthalmos, or it can be combined. So, the basic pathology behind the congenital cystic eye is arrest in the invagination of primary optic vesicle. If it occurs in the 2 to 7 mm of stage, it leads to anophthalmic eye. And if it occurs in the 7 to 14 mm of stage, it leads to microphthalmic eye. Cyst occupies in the central orbit in case of anophthalmos, whereas it occupies inferior orbit in case of microphthalmos. As name indicates, histopathology showed some amount of normal ocular development in microphthalmic eye, whereas it's not in anophthalmos cyst. Diagnosis is basically pure clinical, and it's a non-tender cyst present either in a central or inferior orbit, non-pulsatile cyst with or without ocular structure. Sometimes it might be progressive. Pediatric referral has to be done to rule out any ocular anomalies or systemic anomalies. USGB scan and MRI to done to rule out any other pathology associated with that and to know the exact location of the cyst. And a principle behind the intervention is to keep the cyst as long as it's necessary to adequate socket size. The ideal age is 5 years, and early intervention is needed in case of small cyst if it is unable to retain the conformer. In case of large cyst, it is a socket becomes too large, difficult to accommodate the conformer. And earlier, before 2000, surgical excision was the only option. Later on, sclerosing agent came into the place. These are all the various sclerosing agent in which we are using ethanolamine oleate, bleomycin, and fibrin glue in our cases. So the study was done over the period of 2008 to 2023. We included 7 cases in which 2 with the ethanolamine oleate, we used fibrin glue, and in 3 cases we used bleomycin. This is the first case in which we used ethanolamine oleate, in which 0.3 ml of ethanolamine oleate was injected. Resolution of cyst was noted 6 weeks. And conformer of increasing size was advised for the patient. And this is again the same patient after the injection. And this is the second case in which fibrin glue was used. Again, the cyst which occupies the inferior orbit, transilluminant, with a shallow fornix. And after the cyst aspiration, we injected a fibrin glue of 1 ml. And at the third post-op day, it was completely resolved, and fornix formation has been planned later. So this is the first case of bleomycin, in which again inferior orbital cyst, with this MRI picture showing the cyst which is extending till the apex of the orbit. We aspirated 15 ml of amber colored fluid, and after the 20 international unit of bleomycin was injected. And in between, the patient lost follow-up, and he came after 6 months, and later on we injected a second injection. And after the second injection, it was completely resolved, and formation was also done, and the conformer is placed. So this is one more case in which we used a bleomycin, and again it occupies till the whole orbit till the apex of the orbit. And this is after the first injection. The patient had a swelling again, so we have injected a second injection, and later on the cyst has completely resolved. And overall, we used in 7 cases. We have given a sclerosing agent, out of which ethanolamine oleate is a cheap drug, but it's not easily available. Whereas in the fibrin glue, the duration of resolution was 2 to 3 days, but it's very expensive. The bleomycin is the cheap drug, but the duration of resolution is 6 months in this case. So if the cost factor has been eliminated, fibrin glue is the best sclerosing agent that can be used, and in otherwise, bleomycin is the best with the cheaper availability and the duration of action. Thank you.
Are you using any device like CT guided, ultrasound guided?
No, sir. Basically, the diagnosis is full of clinical. To know the extent and the location and the site of the cyst, we have used MRI. And after the injection, we again order MRI after 4 weeks. And we'll look for a resolution of the cyst is there or not. So if at all resolved completely, we'll go for a further management. And if not resolved, we plan for the next injection.
Sometimes you are aspirating.
Yes, sir. We are aspirating.
The best tool is to aspirate. To aspirate, then you can use ultrasound guided. Very easy.
Yes, sir.
And
Ultrasound can
the
be done.
ultrasound we can make
ultrasound guided. Ma'am, in the first case we used ethanolamine oleate. In that case, with the one injection itself, it resolved. Like later on, it's a very huge cyst in which the shallow fornix was noted, and it obscures the whole orbit and till the apex. So in that case, it necessitated the three injection maximum we have given, and we have followed up over the every 4 weeks, and the patient after 2 months also has recurrence has occurred.
Other cases you did not.
Ethanolamine oleate didn't present with recurrence. Again, with fibrin glue also didn't present with the recurrence. Bleomycin had, and but the cheaper and easy availability make it used in all the cases. Thank you, sir.
How does it act actually?
Sir?
Sclerosing agent. What is the action?
Sir, and the ethanolamine oleate, it actually creates an inflammation and endothelial thrombosis it creates, and thereby it causes sclerosing. Whereas in fibrin glue, again it is a coagulant, it contracts the tissue. Once the aspiration has been done, it contracts the tissue. Bleomycin, again it acts by creating a fibrosis and inflammation.
Okay.
Thank you, sir. Thank you.
The next speaker is Dr. Suganya on retinochoroidal manifestations on multimodal imaging, management of choroidal osteoma, long-term study.
Good morning. My paper is on retinochoroidal manifestations on multimodal imaging and management of case series of choroidal osteoma. Introduction. Choroidal osteoma is a benign ossifying tumor where mature bone replaces the choroid, mostly asymptomatic. Females are mostly affected, mostly unilateral, and affects teens or people in early 20s. The purpose. Choroidal osteoma is a rare benign tumor causing visual decline over time due to various macular complications like SRF, CNVM, decalcification, etc. We analyze the demographic variables, clinical manifestations, multimodal imaging features, complications, and management of choroidal osteoma. So methods. This retrospective single center study included 19 eyes in 17 patients of choroidal osteoma. The demographic variables like age, gender, laterality, and retinochoroidal manifestations on multimodal imaging were studied. All patients underwent multimodal imaging like fundus photo, autofluorescence, OCT, OCTA, ultrasound, FFA, ICG. Functional outcome included BCVA at baseline and final follow-up. Results. The range of age group was 19 to 79 years, mean age 37 years, mean follow-up of 36 months. Clinical manifestations. 10 patients were asymptomatic and 7 patients were symptomatic. Gender ratio. 35% were males and 65% were females. Laterality. 2 patients had bilateral presentation and 17 patients had unilateral presentation. Location. Peripapillary lesions were seen in 4 eyes, submacular lesions in 9 eyes, and extramacular in 6 eyes. The fundus photo showing the peripapillary, submacular, and extramacular locations. Coming to the clinical findings. Non-neovascular SRF was seen in 6 eyes and neovascular SRF was seen in 3 eyes. Type 1 CNVM in 5% and type 2 in 11%. The significant OCT findings. Horizontal lines were seen in 4%. Horizontal choroidal lamella were seen in 9 eyes. Vertical choroidal lamella and tubules in 3 eyes. Multiple hyperreflective dots with hyporeflective spaces in 4 eyes. Cement lines in 4 eyes. Speckle compact bone in 5 cases. Choroidal occultation of fluid in 1 case. Choroidal cavern in 1 case. So these are the OCT findings showing the choroidal occulation of fluid, multiple hyporeflective dots with hyporeflective spaces. It's a choroidal cavern with RPE atrophy. Treatment. The spontaneous resolution of SRF was seen in 1 case. Successful resolution post PDT was seen in 1 case. Anti-VEGFs were given in 29%, out of which 12 cases were recalcitrant, and there was complete resolution with aflibercept switch in 1 patient. So it's a case 1. The patient had peripapillary choroidal osteoma involving the macula. She was not willing for anti-VEGF agents. She was advised observation and she came back after six weeks and there was spontaneous resolution of SRF. So case 2, patient had left eye choroidal osteoma nasal to the macula with subretinal fluid. Octa showed network in the RPE fit, which was suggestive of choroidal osteoma with type 1 CNVM. She didn't respond to conventional anti-VEGFs, but she showed complete resolution with aflibercept. This is a case 3. Patient had choroidal osteoma with subretinal hemorrhage. She underwent PDT. 1 month later, there was complete resolution of CNVM and there was resolution of subretinal hemorrhage. We can see staining of the scar tissue post treatment in FFA. So systemic associations. Erdheim Chester disease was seen in 1 case, ocular syphilis in 1 case, and high myopia in 1 case. So conclusion, the newer multimodal imaging findings helps in early diagnosis, precise and early detection of complications of choroidal osteoma resulting in visual decline including CNVM, non-neovascular SRF decalcification, and helps in effectively managing them. So choroidal osteoma per se needs only close observation. Anti-VEGF agents are the first line of treatment in SRF related to osteoma. The presence of SRF in the absence of CNVM may resolve spontaneously or respond with anti-VEGFs, or it may be resistant to injection. If associated with CNVM, then anti-VEGF agents are the first line of treatment. Newer anti-VEGF agents can be tried in refractory cases. Thank you. Sir, aflibercept we have tried in 1 patient, sir. So patient was initially treated with brolucizumab and ranibizumab. Bevacizumab and ranibizumab. She didn't respond. So we then switched to aflibercept. She showed complete resolution and the effect persisted for more than 3 months, sir.
So I have just 2 questions. One is that did you find any novel findings during multimodal imaging in choroidal osteoma that have not been reported in the literature?
Ma'am, everything is already there in the literature, ma'am. We had a choroidal localization of fluid in 1 patient, choroidal cavern in 1 patient. Other findings were there, conventional findings only, ma'am.
Okay, and did you also study the visual outcomes?
Yes, ma'am, we studied the visual outcome, ma'am.
So how did it respond to treatment?
So recalcitrant patients were there, ma'am. 12% were recalcitrant. So 5% responded completely to PDT.
Okay.
Seema question, please. Dr. Seema. Yes, madam. Here or anyone? Can set up. Can save some time. To save some time. To save some time, I'm calling you early. If no questions, it's okay. We can start.
Okay, good morning, everybody.
Hall manager.
Good morning. Today I shall be talking about dysregulation of melanogenesis pathway in uveal melanoma. Uveal melanoma is the most common intraocular malignancy in adults. It arises commonly from the choroid and then few from ciliary body and iris. Metastasizes mainly to the liver, and this is the cut section of eyeball showing a choroidal melanoma.
Time for saying panel.
Now, there are several clinical and histopath high-risk factors in uveal melanoma.
You are confusing.
Pathological factors like large tumor diameter more than 15 millimeters, epithelioid cell type, these are the epithelioid cells with prominent nucleoli. Hyperpigmentation, ciliary body invasion, scleral and extrascleral invasion, and this is scleral invasion, tumor infiltrating lymphocytes and tumor associated macrophages. So, hyperpigmentation or increased pigmentation in uveal melanoma generates immunosuppressive and mutagenic intermediates that boost tumor growth, and high melanin levels promote their spread and increase resistance to chemotherapy and radiotherapy. Hyperpigmentation also contributes to hypoxic conditions and associated with distant metastasis studied in cutaneous melanomas. Now, hypoxia-inducing factor HIF1 alpha regulates the tumor environment in the presence of hypoxia. MITF or microphthalmia-associated transcription factor binds to HIF1 alpha promoter and stimulates its transcriptional activity. So, high expression of HIF1 alpha has been seen in many cancers, including uveal melanoma, but importance with pigmentation has not been studied. So, we aim to explore the crucial role of MITF and its association with melanogenesis markers TRP1, TRP2, SILV, and HIF1 alpha in uveal melanoma. So, fresh tissues and formalin fixed paraffin embedded sections of 82 uveal melanoma patients and 15 normal choroid samples were taken as controls, which was collected over a 4-year period. Immunohistochemistry and real-time PCR were done to see the expression. So these are the demographic details of the 82 melanoma patients. As you can see, 72% patients were more than 40 years and there was a male preponderance, and high pigmentation was seen in 74% of cases. Distant metastasis was seen in 9 cases, of which 3 patients died. Follow-up was there for up to 48 months. So we also did the pigmentation grading. We did the clinical grading, which I have not shown over here due to time constraints, but pigmentation grading was done on light microscopy, and less than 30% was taken as low pigmentation and more than 30% was taken as high pigmentation. This is the picture showing highly pigmented uveal melanoma. So we studied the immunohistochemical expression of these melanogenesis markers, TRP1 and TRP2. Both of them, 48% was seen in high pigmented UM and TRP2 was seen in 59% of high pigmented UM. SILV protein was expressed in 70% of high pigmented melanoma cases, and MITF had nuclear expression, which was expressed in 56% of high pigmented uveal melanoma. HIF1 alpha was also overexpressed in high pigmented, around 48%. So we studied the association of TRP1 with clinicopath parameters, and as you can see, the statistical relevance was seen with large tumor diameter, clinical TNM staging, high pigmentation with TRP2. With SILV also it correlated well with clinical TNM staging T3, T4. Nuclear MITF also correlated with high pigmentation, and HIF1 alpha correlated with large tumor diameter, high tumor staging, high pigmentation, nuclear BAP1 expression. mRNA also showed increased expression with MITF in comparison to normal choroid, along with SILV, which also showed a fold change value of 4.2. So Kaplan-Meier analysis for all the markers is shown over here, and they all showed metastasis reduced free survival, which was reduced with all the markers, but nuclear MITF showed statistically significant with metastasis-free survival. So to summarize, high expression of melanogenesis markers, TRP1, TRP2, SILV and MITF were found in all high pigmented UM cases, both at the protein and mRNA levels, and Kaplan-Meier showed reduced metastasis-free survival in 82 and 86% of UM patients with TRP2 and SILV. But among all the markers, it was MITF which was statistically significant with reduced metastasis-free survival. On multivariate analysis, MITF expression came out to be an independent prognostic parameter, and melanogenesis pathway contributes to hypoxia in uveal melanoma, and high pigmented cases correlated with increased HIF1 alpha expression. So currently there are no direct inhibitors for melanogenesis markers. We need to do translational studies further, and this may pave the way for new targeted therapy. Thank you.
So
Very
it's
good.
Good study actually.
Thank
Good
you.
study.
How many cases you have done? Around 80%.
These were 82 cases that we had collected over 4-year period.
And how many follow-up anything?
Follow-up was for about 6 to 48 months. That was the maximum follow-up.
What was the period of study?
4-year period,
Yeah, when?
2018 to 2021.
you have a infrastructure that grow
Yes.
facilities?
Yes, we have a lab.
Thank you.
Thank you.
Sefali, if you are not ready, then I can call the next. Okay, next, doctor. Yes, her slide is ready. Okay, please check. To save some time, that I just request Dr. Sanjay.
Yeah.
Dr. Sanjay.
Ready.
No, you can start.
Yeah, yeah.
Dr. Sanjay, after 1 minute, 2 minutes, please stand in the other.
Good morning. The title of my paper is Ocular Tail of Misfolded Protein. It's a case series of conjunctival amyloidosis. So amyloid protein, we know that it is a misfolded protein. It does not provide any structural support. It gets deposited in the organs and it leads to organ dysfunction. So the current nomenclature of amyloidosis includes primary, secondary, and heredofamilial, which actually depends on the protein that has been deposited. The main concerning factor about amyloidosis as a disease is the systemic involvement, wherein the major organs can get involved and which can be life-threatening. The ocular adnexal tissues, when involved, can eventually lead to systemic involvement. Ocular amyloidosis is just 4% of the localized cases. It can affect any tissues of the eye. And when we review the literature, only a handful of series exists, and the highest one from the Moorfield group and only one from the Indian subcontinent. So the challenges we face with this disease are that it is extremely rare, diverse presentation, there's no consensus on the treatment strategy, and it is a telltale sign of a systemic amyloidosis. So keeping all these things in mind, we wish to add to the knowledge that is existing in the literature and share our experience through this large case series. It was an interventional case series, retrospective, and 16 eyes of 13 patients with a mean age of 49.6 years, and the mean duration of symptom was 41.5 months. Males predominated in our series, and the most common referral diagnosis made was ptosis. And the second most referral diagnosis was lymphoma, that is conjunctival lymphoma. Interestingly, on everting the ptotic eyelid, there was a diffuse mass seen, which was causing the mechanical ptosis. In fact, histopathologically, 3 cases had undergone incision biopsy, and amyloidosis could be proven only in 1 case. So histopathological misdiagnosis was also seen in the series. Subconjunctival hemorrhage was something to note, both in the history and sometimes in the presentation, obscuring the mass. Why? Because amyloid actually gets deposited in the vessels, leading to disrupture, and hence subconjunctival hemorrhage in these cases. So in our series, the symptoms included mass, drooping of eyelid, foreign body sensation, eyelid swelling, subconjunctival hemorrhage, and the signs 100% conjunctival mass, and ptosis was the second most common. The mass could be confluent, fusiform, or polypoidal papule. But what was to note was the color. That is, a yellowish hue could be seen in some area of that mass if carefully looked. Site of involvement, bulbar conjunctiva was the most commonly involved. Multifocal involvement was seen in 50% of our eyes, and bilaterality was seen in 23%. So this is a case I just showed. The other eye actually showed a bulbar and a caruncular mass. This lady was referred after incision biopsy of her right eye for initial mass. The other eye, which was told that it is a senile ptosis, actually had a mass deposited in the upper tarsal conjunctiva. So amyloid deposition was missed actually in the 2 referred cases. So stepwise management plan included making a clinical diagnosis and then treatment options, which included excision biopsy, debulking if it was a diffuse lesion, cryotherapy in the lesions, and for ptosis repair, levator resection was done. What was to note in histopathological examination was the characteristic apple green birefringence, which cleansed the diagnosis. The next very important step is to now categorize whether it is localized or systemic, and a baseline workup has to be done in all cases. For us, in all cases, it was normal, and hence proving it to be a primary localized conjunctival amyloidosis in all our cases. Regular follow-up was done, and only in one where it was a diffuse lesion and could not be treated fully in the first setting, it progressed. So a good result after our treatment. So this is just a review of all the cases that I have presented, the results. So this is the largest series from the Indian subcontinent, the second largest globally. And what I would like to highlight here is, even if we have a very subtle mass, like a concretion looking mass in the upper tarsal conjunctiva, or a bulbar lesion obscured by a subconjunctival hemorrhage, maybe looking like an OSSN, maybe looking like a lymphoma, fornicial lesions, caruncular lesions, if we clearly look at the clinical pointers and some pointers from the history, we can actually clinch the diagnosis, because it is very frequently misdiagnosed, and hence the rate of biopsy that has to be done in these cases is also higher. So mismatch management is also common. This is a very good paper by Damaco, which proves that if the patient is diagnosed with systemic amyloidosis, 11.8% were diagnosed to have ocular involvement. In fact, they say that it was underdiagnosed because they could only review the cases in which they presented with an ocular symptom. So hence this was an underestimation. What I would also like to highlight is if a localized amyloidosis cases is detected in your clinic, 10% are the chances that it is associated with systemic amyloidosis eventually, 15% with the coexisting malignancy like a lymphoma. On review of literature, I could find these are the most commonly involved organs, and if bone marrow is involved, it has a poor prognosis. But in our series, till now, with the median follow-up of 4 years, none had a systemic involvement. This is a paper by Shields which shows the tests that should be done. In our practice, we follow these lists of tests for all our cases, and a very close follow-up yearly with the tests has to be done because progression is known. So I would just like to conclude that this is a very rare disease, but we can see it, especially if you have an ocular oncology practice. And because of the life-threatening implications, it is important to detect it and hence have a multidisciplinary approach to actually diagnose systemically and to keep them on follow-up. Thank you so much.
Very good cases. Before asking the question, I just request Dr. Nilanjan Chaudhary to please report here. Dr. Chaudhary. No, okay, option. Okay, then next are, just wait. Just Abhishek Upadhyay, please. You can just okay. In your case, you mentioned that is earlier it was not detected. Can you highlight some points why it was not detected?
So one was a very common misdiagnosis was a ptosis, which was a mechanical ptosis. So 2 patients actually were referred saying for us that do a ptosis surgery, but on eversion of the lid, there was a diffuse lesion. It was not like a papule or a nodule, but the color could be.
Thank you. Your answer is most of that's a take-home message. We should evert
the eyelid. Yeah.
In ptosis also we can evert the lid if it is not a congenital one, or that's a take-home message. Thank you.
Yeah, thank you.
अभी नहीं है अभी सुनो अभी बहुत we are late. Your hall manager was not there, paper was handed but 20 minutes back ना अब कुछ नहीं हो सकते क्या कर सकते बट थोड़ा बाद में बात करेंगे अभिषेक उपाध्याय
So very good morning to everyone.
Hello.
Should I start? A very good morning to everyone. I will be presenting a free paper on role of diagnostic choroidal biopsy in suspicious choroidal lesions. So choroidal lesions are generally diagnosed on the basis of clinical features and combined with multimodal imaging. The diagnostic accuracy of clinical and imaging methods for medium-sized and large tumors is around more than 95% in experienced clinicians. Approximately in 30% of the patients with choroidal metastasis, they have no detectable primary tumor at the time of presentation. So the purpose of this study was to enhance the role of diagnostic choroidal biopsy in suspicious melanotic or amelanotic choroidal lesions. So it was a retrospective case series including 3 patients. The patients underwent detailed ocular examination including multimodal imaging and nuclear scans. Due to a suspicious nature of the lesions, the patient underwent choroidal biopsies via transretinal route, either via 25 gauge cutter or a 24 gauge syringe. The samples were then sent for histopathological examination for the confirmation of the diagnosis. So this is the case 1. This is regarding a 60-year-old female who complained with the decrease in vision in the right eye since the last 4 months. We can see a large pigmented choroidal lesion which was noticed at the posterior pole involving the macula. On ultrasound B scan, a multilobulated heterogeneous lesion was seen with medium to high internal reflectivity. In the ICGA, and FFA is not shown here, ICGA we can see that there is a hyperfluorescence which was there in both the early and the late phases. The OCT is very characteristically showing a lumpy bumpy choroid along with subretinal fluid and sciatic cavities as well as intraretinal fluid. We can see the compression of the outer retina. So a probable diagnosis of choroidal metastasis was considered, and the patient was advised to undergo a whole body PET scan for detecting a primary cancer. However, no uptake was noted. So a choroidal biopsy was performed using a 25 gauge cutter. On histopathological examination, atypical cells were noted, and on immunohistochemistry, we could see that the cells were positive for HMB45, which is a specific marker for choroidal melanoma. Based on the tumor dimensions, which was more than 10 mm in diameter, the patient was given an option for tumor endoresection instead of enucleation, and the patient underwent endoresection of the choroidal melanoma and was doing well in the postoperative period. This is the case 2, which is a 48-year-old female with decreased vision in the left eye since last 3 months. We can see a large amelanotic choroidal lesion superior to the optic disc along with inferior exudative retinal detachment. On B scan, we can see a plateau-shaped heterogeneous lesion with low to mid internal reflectivity on A scan. On FFA ICGA shows hypofluorescence all throughout all the phases, and on OCT we see a characteristically lumpy choroid with the presence of SRF. Based on the clinical and the multimodal imaging, a diagnosis of presumed choroidal metastasis was made. The patient underwent whole body PET scan and no primaries were noted. In view of strong clinical suspicion, a diagnostic choroidal biopsy was done using a 24 gauge needle. On histopathological examination, atypical cells with high NC ratio were noted, and on immunohistochemistry, CK7 positivity and CK20 negativity was seen. The cells were sent for further immunohistochemistry, and it was positive for napsin and TTF1, confirming the diagnosis of a lung adenocarcinoma. The patient was referred back to an oncologist for further assessment and treatment. A case 3, which was a 39-year-old female with the complaints of diminished vision in the right eye since 1 month. Large amelanotic lesion was noted nasal to the optic disc with surrounding subretinal fluid. There was an absence of drusen or any orange pigments clinically. B scan showed a dome-shaped heterogeneous lesion with a very low internal reflectivity. Lesion was hypofluorescent on ICGA, but there was leakage seen along the vessels on FFA, and OCT of the lesion revealed a smooth dome-shaped lesion with hyperreflective material noted in the subretinal space. On PET scan, uptake was seen in the eye, but no primary was noted. And we can also see in the OCT there are inflammatory vitreous cells. Patient underwent a diagnostic choroidal biopsy. Cytological examination revealed an aggregate of epithelioid cells forming granuloma along with lymphocytes and plasma cells. There was no evidence of central necrosis. On GMC stain and ZN staining, there were no organisms which were revealed. Based on negative findings from malignancy, a diagnosis of choroidal granuloma was made, and the patient was investigated according on that line. So choroidal lesions can sometimes present with diagnostic dilemmas, and histopathological analysis may be required to reach a definitive diagnosis. Choroidal biopsies are of utmost importance when multimodal imaging poses a dilemma. The biopsy results may influence patient care and subsequent outcome. Immunohistochemical staining in patients with choroidal metastasis can help to locate the primary tumor and facilitate future treatment. In the current era, in which majority of biopsies are now performed for prognostic purposes, we present a small case series that posed a diagnostic dilemma where diagnostic choroidal biopsy help us make a more precise diagnosis. Thank you.
So nicely presented. Do you do whole body PET-CT imaging for these cases?
Yes.
You did in all these cases?
Yes.
So was it helpful in locating a primary or?
None of the three. First case, it was eventually a choroidal melanoma. No primary was noted. Second case was actually a choroidal metastasis. Still on PET scan, we did not we did not pick up any primary. On the basis of biopsy and immunohistochemistry, we were able to reach to a probable diagnosis that the patient might be of lung adenocarcinoma. And then we referred to an oncologist. Then they took a lymph node biopsy, and then it was positive.
So neither the lymph node nor the lung lesion was picked up on whole body PET-CT? Okay.
Very interesting. Okay, our next present that, please. Dr. Lata Singh, and I also request Dr. Niraj Kumar Sahu, please, after 3 minutes, please, to save time.
Good morning all. Today I am presenting decoding tumor heterogeneity in uveal melanoma using whole exome sequencing. So it's a technique which is the most important in this era for the genetic alterations. So as we all know that uveal and cutaneous melanomas are clinically different, and they both are arise from the melanocytes, but the biological and they are the genetically distinct tumors. So as already Dr. Kashyap has told about the uveal melanoma, so I'll skip these slides because these are like very common, like uveal melanoma is a malignant intraocular tumors, arises from the choroid. So the incidence rate of is higher in white and than Asians. The main important of this study is to study the genetic differences, whether it is different in whites and in Asians. So these are the histopath high risk factors, clinically and pathologically, and these are the H&E slides of histopath high risk factors, which is like extracranial deposits, ciliary body invasion, TILs, and increased pigmentations. So there are various target therapies which are ongoing in uveal melanoma, but in AIMS we are using nivolumab, which is the PD-1 immunotherapy for uveal melanoma. So coming to the genetics of uveal melanoma, as we all know that GNAQ and GNA11, they are mutually exclusive mutations. It means that they both are they are present, but not both are in the same patients. So maybe one patient has a GNAQ and other patient has the GNA11s, but they are not equally present in same patients. So BAP1 is the most important prognostic mutation in and this often results in the absence of the nuclear BAP1 expression using IHC, in which centers don't have the facility of exome sequencing. So we know that whole exome sequencing mainly sequence the protein coding region, which might cause or affect the disease. So these mutations, such as loss of function mutation in BAP1, they are strongly associated with the poor prognosis and metastatic risk. So genetic profiling from whole exome sequencing provide data to design and enroll the patient in the clinical trial, targeting specific mutation or the pathway which are associated with these genes. So these are the very few literature on whole exome sequencing in Indian patient, but nobody has done the whole exome for the more number of the patients. So the objective of this study is to perform the whole exome sequencing to unveil the molecular spectrum of the somatic variations in Indian population, as we are only showing the mutation in the tissue samples. So that's why we are showing the somatic variations. So this is the methodology in which we have taken the tissue samples. Number of the patients was like 56. We have isolated the DNA, making the library, and then the exome enrichment to amplify our gene mutation, and then we go for the Illumina for the sequencer. And then we analyze our mutations in secondary and the tertiary analysis. So these are the clinical details of all the 56 patients, in which the thickness was higher in 49 cases, scleral invasion was found in 24 cases, increased pigmentation was found in 37 cases out of 56, metastasis was found in 11 cases. So coming to the type of variation, as I have already told you that the GNAQ and GNA11, they are mutually inclusive. Mutations, so GNA11 was found in 38% and GNA11 was found in 62% of the cases. So pathogenic variation, which are important for any disease, we found in 4% of the cases in uveal melanoma. So these are the important genes which we found in our cases. So the total pathogenic variation and the most different mutation apart from the BAP1, SF3B1, E1, F1, AX, and the GNAQ and G11, there are the various genes which are mutated in our cases, and they are pathogenic, means they are causing some disease effect in these uveal melanoma patients. So the most frequent pathogenic variation was ITP-KB, HNF1A, POL mutation, and RAD50 mutation, which are different from the Western countries, which they have showed in their literature. So these are the heat maps of these mutations, in which we found the RAD50, KM2C, GNAQ mutation, HNF1A mutations. So these mutations are found in number of the patients, in which the most important one is the BAP1, we found in 13 cases. SF3B1 we found in 29 cases. KMT2C we found in 31 cases out of 56 cases. So if we'll go with the BAP1 and GNAQ, we found BAP1 in 12 cases, which is 22.64. GNA11 was found in 37. And when we compare the BAP1 mutation and the GNAQ, we found in 5% of the cases. And GNA11, with BAP1, we found in 15% of the cases. And in the literature, it is shown that GNA11 are more aggressive cases. So these cases were more important for the next, they are having the high metastatic potentials. So these are the numbers of the cases in which we found our gene mutations. Similarly, we found these variation at different chromosomes. We found at chromosome 3, which is important for uveal melanoma, ATR, BAP1 and BAP1 ATR in 1 cases. We found more variations in chromosome 2 also, chromosome 9, chromosome 7. We found the most important KMT2C in chromosome 7. So these are the molecular pathway which are associated with the pathogenic variation, which is the most important pathway is the angiogenesis, hypoxia activation, as ma'am already shown about the hypoxia related genes in and the inflammatory pathways. So the future aspects of these studies, like there is need for more extensive studies, research focusing on the Indian population to validate these findings along with the functional validation and explore the population-specific genetic markers. And thank you. Yes, sir. No problem. Thank you, sir.
Yes.
Next is our Anushka Nanjali. Please, moment start. No, just no need right now. Moment we can start the discussion, please stand. Okay.
Good morning, everyone. In one of the previous presentations, we saw most of the multimodal imaging findings in choroidal osteoma. What I'm going to talk about is more of a longitudinal study discussing how it grows, increases in size or decreases, which gave us some clue about the deossification dynamics and the natural history. As you all know, it's a benign ossifying tumor which can increase or decrease in size. And there have been papers in the past, mostly by the Shields group, which talk about the long-term follow-up and the predictive factors. But most of these studies are from the pre-OCT era. And in subsequent papers on multimodal imaging in choroidal osteoma, the definitions of certain aspects like deossification is very unclear. So that is why we aim to analyze the multimodal imaging findings and the longitudinal changes and try to define some of these aspects properly. So this was a retrospective observational study of all cases of osteoma from 2012 to 2024, and we included most of the demographic findings and imaging findings. The first term we tried to define was deossification choroidal atrophy, which is kind of an end stage of deossification process. Because it's kind of a process, so it's difficult to measure. So we took the end stage, and it was defined by absence of osteomal lesion with visible choroidal vessels and thinning of choroid on OCT. Next, we tried to define RP atrophy, that was yellowish white discoloration seen as hypoautofluorescent area on FAF and transmission defect on OCT with or without deossification. From almost 14,000 files we screened, we came to around 100 eyes of 80 patients, making it one of the largest series ever reported of choroidal osteoma. Coming to the results, most of the patients were females and had unilateral involvement, but we did not find any systemic associations in any patients. So this is a case of uncomplicated choroidal osteoma. We can see that it looks kind of mildly hyperautofluorescent on autofluorescent imaging without any CNVM or deossification. We saw deossification choroidal atrophy in almost 38% of eyes and RP atrophy in 82.6% of eyes. Now, initially we thought there was some kind of age relation in these changes, but as you can see in this graph, RP atrophy tend to appear almost a decade before deossification. But when we did a multivariate regression analysis, we found that it was the total area of the choroidal osteoma that was more predictive of deossification and RP atrophy. Coming to the longitudinal changes, we saw an increase in the total lesion size, an increase in ossified area and the deossified area. Now something was odd. Increase in one should have been accompanied by a decrease in another. But we could see this because of cases like this, where there was an increase in deossification in one of the poles and an increase in the osteoma lesion from another pole. We also found these hyperreflective cavitations that tend to appear During the process of deossification, as you can see in this image, the osteoma size is decreasing with increase in cavitations. We could also see that in eyes which are having increase in osteoma thickness on OCT, most of these patients had SRF development without CNVM formation, as we had previously seen, and it was statistically significant. So coming to, based on all these findings, we could reach 3 clinical subtypes. One was osteoma without RP atrophy or deossification, one was osteoma with RP atrophy without deossification, and osteoma with RP atrophy and deossification. And if you look closely in these eyes, you can see all of these 3 zones coexisting, and you can confirm it using OCT. Just to conclude, deossification process and osteoma growth can coexist. The higher total area of baseline at baseline can predispose to faster deossification, and an increase in osteoma thickness and size is associated with SRF development without CNVM. Thank you.
What type of OCT is generally recommended in such type of cases?
Sorry?
What type of, there is a different type of OCT. What
Yes.
type of OCT is
A
generally?
swept source OCT will be best because a swept source OCT will be best because it has the maximum depth of penetration and gives us almost the extent of the lesion.
And what about NGO-OCT?
NGO-OCT, it cannot detect the flow or the extent of the osteoma, but it can tell you about the choricapillary flow. I think the next we have another presentation on it. In most of the cases, we have seen that this flow, the choricapillary flow, is well preserved in these cases.
Okay, so generally normal OCT is maybe an injustice for the patient.
OCT is
so either NGO-OCT or that one is very good. Very good. Okay.
Thank you.
Good morning everyone. I shall be presenting on yellow laser photocoagulation of deep conjunctival nevus, a minimally invasive alternative to surgical excision. So as we all know, melanocytic tumors of the conjunctiva constitute 52% of ocular surface lesion, and conjunctival nevus is the most common benign periocular lesion. The diagnosis is essentially clinical, where conjunctival nevus is usually present since birth, is unilateral, variably pigmented, well defined in the interpalpebral location, limited to the limbus. Majority of them have cysts. There can be a change in size at puberty, and feeder vessels can be present, and they do not indicate malignancy always. So to confirm, we can further go ahead with an AIOS2025 where the lesion is seen as a subepithelial lesion with cysts. So ours was a prospective interventional case series where we included clinically diagnosed cases of conjunctival nevus which were stable over a period of 6 months. We performed laser photocoagulation with the help of yellow laser 577 nanometer. At follow-up of 1 day, 1 week, 3 months, 1 month, 3 months, and 6 months, we looked at the efficacy, the safety using ocular keratograph, where we looked into the ocular surface disease index, the tear meniscal height, the non-invasive tear breakup time, the lipid layer thickness, Schirmer's, Oxford corneal scoring. We also looked into the histopathology of the lasered conjunctiva. Results: the clinicopathology correlation of lasered conjunctiva, as there was no previous literature on yellow laser for conjunctival nevus. The first patient that we chose was this particular patient with a conjunctival nevus in an anophthalmic socket. Post laser, the visual changes, the first change we noted was this graying, then cavitation followed by blackening. Blackening we considered the end stage of laser. At this stage, it was removed with the help of a cotton bud. And this is at 1 week, you can see complete removal of the pigmentation. We also looked into the histopathology in this one particular case where the gray part of the visual change corresponded to nucleus fragmentation in epithelium, and in the subepithelia 60% of the nevus cells were still viable, whereas in the blackening change the viable nevus cells came down to 40%. Moving on to the efficacy, we included moderate to severely pigmented conjunctival nevus, 10 eyes of 9 patients with a mean diameter of 4.2 millimeter, the mean age being 30 years, ranging from 6 to 63 years. I would like to draw your attention to the laser parameters. The power ranged from 300 to 600 milliwatt, the duration was 80 milliseconds, the spot size being 200 micrometer. Apart from one particular patient where there was mild conjunctival scarring, I will come to this patient, there was no other side effect seen in any of the patients. There was no recurrence seen at 10 months follow-up. Only in this one particular case, 2 sessions of laser were planned because the lesion was more than 10 millimeter in the greatest dimension. Apart from that, all the other 9 patients, 1 session sufficed to remove the nevus completely. So this particular case, I want to share the lesson learned. You can see in the inferior part, inadvertently the Tennant's capsule was removed, exposing the bare sclera, which resulted into this scarring and some tissue drag there. So the AIOS2025 again showing the removed tenon there. So the lesson learned was, do not laser the Tennant's capsule. There was some transient congestion on first day post laser. However, there were no other changes in any of the ocular surface parameters over the period of follow-up. This is one patient showing over the period of follow-up. On day 1, you can see the epithelial defect there, which eventually healed up. A review of literature showed that there were the 4 existing studies who used argon green laser and frequency double ND YAG for such lesion, but all of them were superficial lesions, and all the patients we did were deep lesions. Thus, to conclude, this is the first study to explore the use of yellow laser for conjunctival nevus. This is the first study in Indians. The visual changes on application of laser are graying, cavitation and blackening, blackening being the end point. On histopathology, the progressive visual changes correlate with decreasing tumor viability. Laser should precisely target the pigmented lesion in the conjunctiva while avoiding the underlying Tennant's capsule. It is a safe and effective outpatient procedure for the treatment of deep conjunctival nevus, offering excellent cosmetic outcomes with no significant side effect. Comparing with surgical excision, which has been the standard of care till date, this is a OPD-based simple procedure with quick recovery, cheaper, no need of any local or general anesthesia, no significant side effect. The only con being there is no histopathology confirmation. There, the clinical examination is of utmost importance before doing this procedure. Thank you everyone for a patient listening.
How does it act actually?
So the mechanism of action is the yellow laser energy is absorbed by 2 things. One is melanin present in the nevus cells, the melanocytes and the basal epithelium, and hemoglobin present in the blood vessels. So they absorb yellow laser energy, convert it into heat, and heat coagulates protein, and once it becomes coagulated, it can be removed with the bud. So that's the mechanism of action.
Can you do something like impression cytology to see that it is removed fully or not? So you said there is no conclusion that it is removed fully or not. Can you do something kind of?
So impression cytology helps us in finding out whether there is a dysplasia there or not. So here the removal is clinically evident, like you can see it is absolutely gone at the end of the procedure. So I don't think impression cytology will help.
But is there any chances of metastasis?
So these are all benign conjunctival nevus that we have included. We are not doing this for conjunctiva melanoma. So
that's why I'm asking. So how can you confirm? So
correct.
It's not it's a benign.
Yes, true. So that's why we have like the clinical clenches for conjunctival nevus, as I highlighted, and we have also included patients who were stable over a period of 6 months with no documented progression.
It's a good study.
Thank you. Thank you.
Good morning everyone. I am Nayan Jacob and I will be presenting the third talk on choroidal osteoma today, but I will be concentrating more on its complication, that is CNVM. So it's a benign ossifying tumor where a mature cancellous bone replaces the choroid. Its etiology is elusive and there is no known ocular or systemic risk factor. And this choroidal osteoma can complicate and form a CNVM, which ultimately leads to visual loss. The purpose of our study was to analyze the clinical characteristics and follow-up of eyes with CNVM complicating choroidal osteoma. It was a retrospective multicentric study done with the help of electronic medical records conducted from 2012 to 2024. We included patients with diagnosis of choroidal osteoma and CNVM, and we included patients with age more than 18 years, no history of ocular surgery or systemic comorbidities. We collected demographic data, clinical findings, imaging details, that is fundus photo, autofluorescence, FFA, ICGA, OCT and OCT angiography, its treatment done, and the follow-up are also documented. So in total, we had 73 patients or 92 eyes with choroidal osteoma, which included 37 males and 36 females. And out of that, 41 patients or 44 eyes had CNVM, that is 17 males and 24 females. In terms of the location of the choroidal osteoma, majority of the patients, that is 72 of the lesions, were involving the macula, and nearly 12% involved the peripapillary area, and the rest 3% were in the periphery of the retina. When we compared the age of presentation in eyes with CNVM and without CNVM, the eyes with CNVM presented earlier at an age of 28 years compared to those without CNVM with a mean age of 34 years, but this was not statistically significant. Similarly, when we compared the visual acuity at presentation with eyes with and without CNVM, though the eyes with CNVM had a poorer visual acuity of 0.4 logMAR units, it was not statistically significant. We also conducted multimodal imaging analysis in eyes with choroidal neovascular membrane. On FFA, we could note an early hyperfluorescence with late leakage, and the tumor tissue was also staining with the dye, whereas on ICGA, a well-defined neovascular net with minimal leakage is noted. On OCT, subretinal hyperreflective material, SRF, intraretinal fluid, RP and outer retinal loss were noted, and on OCT angiography, minimal to patchy areas of choricapillary loss and neovascular network was noted. So this is a slide describing the multimodal imaging findings. In image A, we can see a choroidal osteoma seen as a hypopigmented yellowish lesion, approximately 5 disc diameters in size along the infratemporal arcade, and where the arrow points, we can see a subtle subretinal hemorrhage. In this FFA frame, we can see where the arrow points an area of hyperfluorescence and leakage surrounded by an area of hypofluorescence corresponds to the subretinal hemorrhage, and below that we can see the area of staining of the tumor. In this ICJ frame, similarly, this arrow points to the area of CNVM network, and surrounding that we can see areas of choricapillary loss, and this area we can see both the intratumoral vessels and the pushed out outer choroidal vessels. OCT angiography also shows this well-defined neovascular network and this area of choricapillary loss and the deep choroidal vessels. On OCT, this subretinal hyperreflective material can be seen along with the presence of subretinal fluid, intraretinal fluid, and intraretinal fluid. When we analyze the factors affecting CNVM at baseline, we notice that the presence of deossification, presence of baseline RP atrophy, and its location being foveal or perifoveal increases the risk of CNVM formation. In total, among all the eyes with CNVM, 12 eyes had scarred CNVM, and all the other eyes with active CNVM were treated with anti-VEGF injection, except one which was treated with focal laser, but it was away from the macula. And all the eyes received a mean of 4.1 injections throughout the treatment course. And at a mean follow-up of nearly 15 months, CNVM regressed in 56% of the eyes, and improved or stable vision was noted in 12 eyes, or nearly 30%. And during this period, no eyes showed any lateral growth or decalcification. So to conclude, although choroidal osteoma complicating to CNVM is rare, the risk of CNVM formation is nearly 47%, and multimodal imaging helps us in getting an accurate diagnosis of CNVM. The risk factors for CNVM formation are deossification, RP atrophy, and foveal location of the tumor. And post-treatment with anti-VEGF injections, CNVM shows stabilization, CNVM shows regression and stabilization of vision in nearly 30% of eyes. Thank you.
It's a sad story actually. If you detect late, generally
Yes.
there's a scarring. So most of the time, probably we may diagnose. You want to say something? What may be the cause for a? What are the causes for late?
I'm sorry, sir.
Late presentation or late diagnosis? What is the in your experience? Because
Late presentation, maybe if the choroidal osteoma is located in the subfoveal area, because of the decalcification, still the patient may have a loss of vision. So we may not, and because and we have seen in our series that sometimes the tumor grows into the subretinal space. So it is kind of difficult to distinguish a CNVM from a choroidal osteoma breaking through into the subretinal space. That might be one reason where we are diagnosing the CNVM late.
moment is developed CNVM, it's very difficult to give the restoration. Okay, thank you.
Good morning, everyone. Today I will be discussing one of the masquerades in ocular oncology, that is PVRL. The title of my presentation is RP Undulations in PVRL, Hidden Paradox. I have no financial disclosures. These are the abbreviations I have used in my presentation. PVRL is a rare but represents the most common form of intraocular lymphoma. It is mainly classified as diffuse large B-cell lymphoma, and approximately 80% of the individuals with PVRL eventually develop CNS lymphoma, whereas 20% of the CNS lymphoma cases occur either concurrently or later involving the vitreoretinal counterpart. So the objective of my presentation is to determine the significance of 3 OCT biomarkers, primarily the RP undulations in PVRL, and evaluate the association of RP undulation, secondly the intraretinal infiltration, third the sub-RP or subretinal lesions with the severity indicators, which is first one is the partial regression, secondly subsequent CNS involvement, and third is intraocular recurrence. So it was a multi-centered retrospective study done over a period of 8 years at 3 centers, that is LV Prasad Eye Hospital, PGIMR Chandigarh, and the Mayo Clinic, USA. The inclusion criteria was patients having a biopsy confirmed cases of PVRL, age more than 18 years. The exclusion criteria was patients having media opacity, OCT signal strength of less than 7, and patients having OCT without baseline OCT at the time of presentation. The OCT signs that we have evaluated were, first, the primary one is the RP undulation. The second is the sub-RPE infiltration or the subretinal infiltration. The third one is the intraretinal infiltration. So these are the 2 primary cases, that representative cases. In the first one, we can see the characteristic leopard skin pattern, and now on the OCT we can see the characteristic subretinal and the sub-RP infiltration along with the intraretinal infiltration. The second case, however, highlights my primary indicator, that is the severe RP undulations along with the intraretinal infiltrations. The statistical analysis was done using Jamovi software version 2.53.0. The statistical initial association was assessed using chi-square test and student t-test, and then the association was estimated through the regression analysis, and a p-value of less than 0.05 was considered statistically significant. The primary outcome was the prevalence of RP undulation and its association with the severity indicators. The secondary outcome was the association of other OCT biomarkers with the severity indicators. These were the baseline characteristics. So our study included 134 eyes, biopsy confirmed eyes of 77 patients, in which 26 were the Asian population and 108 were the American population. And the RP undulation were present in 26% of the eyes, subretinal and sub-RP infiltration in the 50%, and intraretinal infiltration in 33.5% of the eyes. So the prevalence of the RP undulation in the Asian subset of the population was 62%. In American, however, it was present in the 15% of the population. The regression analysis, when we estimated the association with the severity indicator, so the first severity indicator, that is the partial regression versus the complete regression, Among that, RP undulation showed the significant association with the partial regression of the disease, having a p-value of 0.005 on the multivariate regression analysis, and with the area under the curve of 0.699 with the specificity of 83.8% and the sensitivity of 44.7%. The second association severity indicator, that is the development of the CNS lymphoma. So in that, intraretinal infiltration showed a significant association on the multivariate regression model with the p-value of 0.01 and with the EUC of 0.786 with a specificity of 92.5% and sensitivity of 36.4%. Now the third severity indicator, that is the intraocular recurrence. In that, however, none of the parameters showed any sort of association with the intraocular recurrence. So with this, we interpreted that the RP undulation were more prevalent in the Asian population than the Americans. It is associated with the partial regression of the disease. The subretinal and the sub-RP infiltration does not show any association, and the intraretinal infiltration shows association with the CNS involvement in the subsequent course of the disease. The limitation of the study was it was a retrospective design study. The subretinal and sub-RP infiltration should be treated as a separate variable, which was considered as a one variable in our study. And it included the different population in which the American Midwesterns would be different from the Eastern or the Western regions. And I would like to conclude my presentation with these 3 pointers, that the prevalence of RP undulation is higher in Asian population than in American population. And the key OCT biomarker, that is RP undulation, we were assessing in our study, is linked to the partial regression of the disease, suggesting that the disease is not limited to the retina or vitreous, as the name suggests, the primary vitreoretinal lymphoma. However, it extends to the choroid also. In addition, in our study, we found that the intraretinal infiltration is associated with the subsequent CNS involvement. Thank you for your patient listening.
One more presenter. Are you at one? No, not. Clinical. What is that? Conduram, a rare case of
Malignant hydroadenoma.
if option, then we can say. Yeah, you are the presenter. Please. Malignant hydroma. I request every speaker to wait. So the winner of this, as per the instruction, winner of this session will immediately start the semi-final with the winner of the previous one. So there is a semi-final immediately. So winner of this session, we will calculate immediately. Then we can call that previous one winner already. Previous session already here. So moment she can start, then we can calculate, we can announce the result. Okay, please.
Good morning, everyone. I'm presenting just a case. It is a clinical conundrum unveiling a rare case of malignant hydroadenoma masquerading as meibomian gland carcinoma. Nodular hydroadenomas is a cutaneous neoplasm that can occur in various locations. It has been referred to a clear cell hydroadenoma or eccrine sweat gland adenomas. Eccrine sweat glands gives rise to intradermal nodules called hydroadenomas. Nodular hydroadenomas are transition between eccrine poroma and eccrine spiral adenoma according to ultrastructure and enzyme histochemical investigations. Typically, they are seen mainly in middle-aged people, more common in females. Clinically, it usually manifests as a single solid cystic intradermal nodule. Here, I will be discussing a case of a 77-year-old male who is presented to us with a right eye upper lid lesion. A case report of 77-year-old male who presented with painless multinodular swelling of right upper lid since 7 years, which was gradually increasing in the size. There was no history of diminution of vision or history of trauma. Here is the on examination of the eyelid tumor. It was multinodular swelling of the right upper lid, size approximately 16×17, ill-defined margins, firm in consistency, immobile, non-tender, fixed to underlying eyelid structure with feeder vessels and leading to mechanical ptosis. Here is the clinical photograph of the patient. The examination of both eyes were normal and patient was pseudophakic in both eyes. Fundus was normal. Coming to the management part, patient was planned for wide excision biopsy with 4 mm clear margin excision and sent for histopathology. Further, patient was planned for Cutler beard 2-stage reconstruction surgery. Early detection and management with multidisciplinary approach may save the patient from debilitating carcinomas. Here is the histopathology report. As we can see in the image 1, the A pointed is towards the fibrous septa, making the multilobulated architecture. B is showing the clear cytoplasm and C is showing the high mitotic activity. Coming to the image B on the left side, the A is pointing towards the cystic space. The white color thing is cystic space. And you can see the B is pointing towards the infiltrative tumor and C is pleomorphism. Coming to the discussion part, tumors arising from the sweat glands of the eyelid are usually uncommon and the difference in their structure have given rise to much confusion. A wide variety of descriptive terms have been applied to sweat gland tumors. Histologically, sweat glands can either be eccrine, apocrine in nature. Eccrine glands are present throughout the skin but most abundant in palm, soles and axilla. In the eyelid, eccrine glands are present in the lid margin and in the surface of the dermis. Eccrine hydradenomas are also referred to as nodular hydradenomas or clear cell hydradenomas arising from the eccrine sweat glands. This nomenclature is based on the electron microscopy and histochemical studies. Clinically, usually they present as a solitary intradermal nodule, but which is well circumscribed and may appear encapsulated. Similarly, here the case is multinodular presentation. However, hydradenomas do not present with discrete clinical characteristics that allow differentiation from the other eyelid tumors on the basis of clinical. We can differentiate them on the basis of clinical and microscopic findings. The differential diagnosis includes primary skin tumors like follicular, sebaceous, sweat gland differentiation. Hydradenomas can mimic as cutaneous metastatic disease from the clear cell tumors such as renal cell carcinoma. The possibility of the primary basal cell carcinoma with eccentric differentiation and the lobular hyalinized syringioma should also be included. Coming to the conclusion, why I am presenting this case. Because of the variation in their structures, tumors originating from the sweat glands of the eyelids are rare and have a great deal of misunderstanding. The sweat gland tumors have been referred to a wide range of words. Malignant hydromas of the eyelid are very rare adnexial tumors, exceedingly low incidence of 0.001%. For early diagnosis, sweat gland tumors should be taken into account while making a differential diagnosis for eyelid tumors. Malignant hydradenomas are distinctly unusual and extremely rare in the eyelid. The possibility of sweat gland tumor should be considered in the differential diagnosis of eyelid tumors to ensure the early detection. And finally, the management involves complete excision of the lesion followed by lid reconstruction. Here are my references.
Okay, fine. Okay. Please go back to your one slide. You are showing the clinical picture. Okay. In such cases, you are mentioning Cutler beard managed by, and two points you mentioned. I am little confused regarding clear margin of 4 mm or 4 or 5 mm and managed by Cutler beard. Is it? I think it's a huge one. Is it possible?
Sir, after the excision, they did Cutler beard reconstructive surgery, but after primary excision was done there and primary closure was done, and after the report only they.
Okay, you can that point.
Yes, sir. It was, yes, sir.
Yes.
Yes, ma'am. Yes, ma'am.
So ideal is this in such cases you can go for a for posterior lamella by mucous membrane of that other, and then you can use a labeller one to reconstruct both the ribs. Okay, thank you.
Thanks.
Now we can start the semi-final immediately. We are already, because of the technical team, we are already behind the schedule, half an hour almost. Just I request the winner of the previous session, Dr. Bishal, please, you can start the session, and after that calculation, I invite the second one, please.
Dr. Vishal.
Please start. Audio visual team, please. Dr. Bishal.
Yes. Okay. So, good morning, one and all. So, I'll be presenting an interesting paper on the ERG changes in the inner and outer retinal layers before and after intravenous chemotherapy for retinoblastoma. So, as we all know, retinoblastoma is the most common intraocular tumor in children, and the current most standard of care for all the children with retinoblastoma, particularly in a low resource country like India, is intravenous chemotherapy. However, we all know this chemotherapies are kind of toxic, not only for the systemic toxicity but also from the intraocular aspect, and the numerous reports of ERG following intra-arterial as well as intravitreal chemotherapy have been published. But the ERG findings after systemic intravenous chemotherapy, which is the standard of care in India, is not very kind of presented or limited. So with that purpose, we wanted to understand whether giving intravenous chemotherapy, especially in children with retinoblastoma in a country like India, do they affect the global function of the retina, especially the inner and outer retinal function. So this was a prospective observational study done at L.V. Prasad Eye Institute, Hyderabad, with the inclusion criteria of all the children diagnosed with retinoblastoma. The data was collected in terms of demographic, clinical features, as well as fundus photograph, including our RETCAM imaging. The methodology what we use currently in our institute is giving intravenous chemotherapy using standard 3 drugs, vincristine, etoposide, carboplatin, every 3 to 4 weeks for 6 cycles. The ERG testing was kind of novel. What we used in our setting was the RETTEL system, which is LKC handheld technology, where we use this technology to image or record the ERG findings in children under anesthesia, both pre and post chemotherapy. The standard ISA protocols, both from the photopic, flash, flicker, as well as PNHR readings were calculated both pre and post, as well as the outcome measures were demonstrated in terms of flash ERG, peak times pre and post, compared with the normal contralateral eye, and the measurement of PHNR amplitude and the PNHR ratio at 72 milliseconds. Just to give a brief understanding what all things we measured as in terms of quantitative measurements of ERG, one is the implicit time, that is the time from stimulus until the peak of activity, both for A and B wave, as well as the amplitude, both for A and B wave. In terms of result, we have total of 6 children, 12 eyes included in our study. 4 children had a unilateral RB, whereas 2 children had bilateral RB. One eye we had to exclude due to primary enucleation. However, the other eye, which was a normal eye, we included in our study. The mean age at presentation was 3 years, ranging from 1 to 5 years. In terms of tumor classification, 1 eye had group B, 3 had group C, and 4 eyes had group D retinoblastoma. Important confounder, particularly in ERD setting where we want to look at the macular function test, 7 eyes had a pre-existing macular involvement of retinoblastoma, as well as 5 eyes had associated retinal detachment and subretinal fluid. In terms of finding, the tumor regressed in all the 7 eyes with retinoblastoma, that's showing 100% response to a standard intravenous chemotherapy. In terms of ERG changes, as you can see in the light adapted, that is A wave and B wave peak time, it kind of delayed in 2 eyes in A wave peak time, whereas in 5 eyes in B wave peak time. In terms of amplitude, I think it kind of decreased in both A as well as B wave in 5 and 6 eyes respectively. Important finding what we could see, there's PNHR finding, which is a specific retinal ganglion cells, which was improved only in 1 eye, where it is decreased in 6 eyes, whereas the PHNR P ratio was improved in all the 7 eyes. So this is a couple of cases where you can see in the patient presented with group D retinoblastoma after 6 cycles of intravenous chemotherapy, there was type 3 regression. Pre-intravenous chemotherapy, the ARG amplitudes are totally flat, whereas post chemotherapy you could see there was a improvement in the amplitude as well as the latency in the A as well as B wave. The another patient where you could see there was a macular location of retinoblastoma, and after 6 cycles of intravenous chemotherapy there was type 3 regression of the tumor. In terms of ERG findings, you could see there was a reduction in the amplitude as well as the increase in the latency for A and B wave, thereby demonstrating that the macular location of the retinoblastoma might be detrimental to future vision potential in these children. The key findings, the normal contralateral eye, there was no detrimental in terms of retinal function except in one eye, and there was no statistical difference between the study and the normal eyes in ERG at follow-up. In terms of visual acuity, because we all know these are pre-verbal children, it will be very difficult to measure visual acuity in these children. The central fixation of the child improved only in one eye, whereas poor fixation in two children. In terms of discussion, more than 50% of eyes showed delayed photopic flash and flicker responses after chemotherapy, despite tumor regression. There was improvement in only one eye, indicating poor recovery of retinal ganglion cells and amacrine cells, and intravitreal chemotherapy had no detrimental effect on the normal contralateral eyes. To conclude, I would say intravenous chemotherapy effects on the retinal function are very complex, and it needs to be influenced by other important confounders like macular location of the tumor and associated retinal detachment. The inner retinal functions, especially PNHR waveforms, improved only 1/5 of the eye, suggesting a long-term effects on the vision development and need for early visual rehabilitation. In terms of future research, we recommend longitudinal studies to comprehensively assess retinal function as well as the vision development in these pre-verbal children, particularly in patients with retinoblastoma post-intravenous chemotherapy. Thank you.
Very nice work. So were they all receiving just intravenous, or anyone received intraarterial or intravitreal also?
No, so the inclusion criteria was to just to look at the intravenous chemotherapy. After 6 cycles, if there was a recurrence, then, but obviously they use adjuvant focal treatment like TTT or even intraarterial chemotherapy. But the limitation of this study, because we wanted to study the effect of chemotherapy, that is especially systemic chemotherapy and pre and post ERG findings, because intraarterial we know it causes detrimental loss of retinal function because of the targeted localization of the drug into the retina and choroidal compartment, and intravenous chemotherapy, again it is published, melphalan causes salt and pepper retinopathy. So I think that is all published. Intravenous chemotherapy, it is not published or it is not known. So that's what we wanted to study from our paper.
And they all got standard dose chemotherapy,
Yes,
6
standard.
cycles,
Yes,
all
yes,
of them.
yes, yes.
Okay, thank you.
Thank you.
So now we are calculating the session B. Everyone just please wait, and then once we can declare as per the instruction from the